Hi, this is Jeff Lighthall from the Department of Anesthesia. This is a video on how to manage patients who've been intubated for COVID-19. The reason for this video is that a number of physicians who are many years away from their last ICU rotation have been tasked to manage ventilators and the respiratory care of critically ill patients during the pandemic. The plan here is to have two videos in this series. This is the first and has a focus on respiratory physiology. It introduces the main concepts and terms underlying ventilation of the critically ill patient. A second planned video on ventilator modes, settings, and strategies for managed ARDS will be forthcoming. Your ventilation and patient care strategy is going to be based on the following clinical factors. The first is the chain of pain, or more formally, the series of events leading to respiratory failure. Other important factors are key aspects of lung physiology, notably compliance, or the pressure-volume relationships of the lung. Secondly, the ventilation-perfusion relationships of the pulmonary microcirculation. And next, it's important to consider how lungs and ventilators interact with each other when ventilation is driven by spontaneous effort versus totally controlled by a ventilator. And finally, it's important to understand how ventilators can hurt you. Severe hypoxemia and hypercarbia just don't appear. There's always a backstory of underlying patient and environmental factors that lead to these changes. Therefore, when caring for a patient with respiratory failure, you want to create a storyline that pieces together the chronic conditions and the acute changes that account for the current clinical picture. In the end, your therapeutic efforts will be aimed at playing this story backwards in order to return the patient to as close to possible as where they started. Important considerations in thinking about the etiology of the respiratory failure are the following. The first is chronic heart, lung, and neurologic conditions, including neuromuscular conditions. Specifically, are there changes in the lung parenchyma, such as fibrosis or emphysematous degeneration? Are there diseases of the airway? And how about the lung vasculature? Is there pulmonary hypertension or problems with chronic thromboembolic disease or other airway disease? And also, what is the patient's overall level of function and work of breathing? And what's your sense of their physiologic reserve? Now you can consider what acute process is involved. Is it pneumonia? Is it something infectious, non-infectious? And knowing all of this will provide a more complete explanation for current problems with gas exchange and work of breathing. And that's what, in the end, you're trying to arrive at, because that will guide your management and therapeutic strategies. So having said this, COVID-19 does create a rapidly debilitating injury to the lungs in some seemingly normal hosts. Nonetheless, the exercise of considering chronic conditions and their interaction with acute processes will serve you well when managing respiratory failure. Let's turn our attention now to a few important aspects of lung physiology. An important issue underlying breathing and mechanical ventilation is lung compliance. Compliance describes the pressure that develops within the lung when a volume of air is introduced and held in it. The static compliance curve drawn here is a common presentation of this concept. When we use lung compliance to describe how a disease is affecting lung function, it is the change in volume over the change in pressure that is being calculated and categorized. This center dot shows the volume and pressure at an expiration of a healthy patient. As you can see, starting on this part of the curve allows the greatest amount of air to move in and out of the lung with the least change in pressure. Normal respiration is quite efficient and requires very little effort. Let's contrast that with someone whose lung volume at rest is much lower. This is applicable to obesity, pregnancy, high abdominal pressures, and various forms of restrictive lung disease. To accomplish a similar tidal volume in these patients, greater change in pressure are needed. As change in pressure reflects the work of breathing, patients who are starting out on the lower part of the compliance curve are prone to greater fatigue with respiration and may progress to respiratory failure because of this workload. Ventilators generate their own gas flow and deliver to the lung either at a set pressure or tidal volume. While a lot of other functions are served by ventilators, they enter this picture as a means of replacing either all or part of the patient's workload. It is also possible to receive partial assistance from a mechanical device, and this is more characteristic of BiPAP and high-flow nasal cannula oxygen delivery systems. So when someone with advanced lung disease is placed on a ventilator, you often see a very abnormal compliance curve displayed, and often they look like this one, where a very small change in volume is accompanied by a very large change in pressure. This stiff lung pattern is the one seen in the adult respiratory distress syndrome, or ARDS. Many COVID-19 patients have presented with hypoxemia, yet very compliant lungs. Patients whose course does not improve can progress to the ARDS type non-compliant lung. In diseased lungs, some of its volume can collapse during respiration. Some of this collapse can be avoided by adding pressure to a breathing system so that the pressure within the lung does not return to zero at the end of every breath. This is the role of positive end expiratory pressure, or PEEP, which is indicated here by the vertical line. With PEEP, you can see that some of the lung volume is retained by the pressure that's added, and also that it may place the lung at a more favorable part of the lung compliance curve for subsequent breaths. The next series of diagrams illustrate the ventilation-perfusion relationships that exist within the lung. Here is a unit that is both ventilated and perfused, representing the predominant situation in healthy lung tissue. Next is a unit with a collapsed or filled-in alveolus. Typically, the lung will constrict blood vessels serving such regions, but as shown here, a right-to-left shunt can develop when blood flow to a non-ventilated lung is maintained. This is believed to be a key factor underlying hypoxemia in COVID-19 and other injuries to the lung. Finally, the last section shows dead space, resulting from lung regions that are ventilated but not perfused. Your evaluation of a ventilated patient often strives to identify sources of ventilation-perfusion mismatch and should lead to strategies to optimize these relationships without creating additional complications. Next, it is important to understand the differences between spontaneous and controlled ventilation. With spontaneous ventilation, air is drawn into the lung by the generation of negative interthoracic pressure. When the diaphragm contracts, the large bulk of lung in the dorsal and inferior regions of the lung are expanded to increase airflow to these regions. In the upright patient, gravity favors blood flow to this region, and ventilation and perfusion are matched with great efficiency to the same area of the lung. Controlled ventilation involves a push rather than a pull of air. An extreme example of controlled ventilation exists when a patient is deeply sedated or paralyzed, such that the diaphragm and other chest wall muscles are no longer participating in ventilation. Because inspired gases are driven into the lung, they follow the path of least resistance, and this path will be into the areas in the anterior and superior part of the lung, because blood flow and alveolar fluids are being pulled into the dependent parts of the lung. Thus you have ventilation occurring in one part of the lung and perfusion occurring in the other, and the matching is not very good. Thus both shunt and dead space ventilation may be exacerbated by the very dramatic change in lung physics that occurs when a spontaneously ventilated patient is placed in some form of controlled ventilation. To make matters worse, positive pressure breaths and PEEP can impair venous return to the heart and lead to hypotension. This is often problematic in newly intubated patients. Positive pressure breath. As air flows into the lung, pressure is generated within the lung, and its numerical value is determined by the lung compliance. When airflow ceases and the breath volume is held within the lung, two general patterns can be observed. One is that similar pressures are seen when the air is no longer flowing through the tubes and airways. In this case, a stiff and non-compliant lung is creating a global resistance to the inspired tidal volume. The other pattern exists when much lower pressures are seen once inspiration is complete. The latter would be a situation where there is better lung compliance. These examples introduce the difference between peak inspiratory pressure and plateau pressures. Peak pressures reflect the resistance generated by the airways and breathing tube, while plateau pressures reflect the elasticity of the lung parenchyma itself, and that which is generally affected by pulmonary processes not directly involving the airways. Ventilators readily display peak pressures, while plateau pressures are determined by generating inspiratory hold, which is a manual maneuver. Plateau pressures reflect the risk for additional lung injury, while peaks generally do not. You cannot always assume that a plateau will be similar to the peak, so you and your respiratory therapist are going to have to take a look. Finally, it's worth knowing how ventilators can hurt you. There's compelling evidence that damage can occur to the lung when certain thresholds for tidal volumes and pressures are exceeded. Some of this injury is cytokine related and part is purely mechanical. Current thought suggests that additional lung injury may result from the constant opening and closing of airways and overdistension of the uninjured lung, particularly as the regions that are spared from disease become progressively smaller and smaller. Also, all forms of damage are exacerbated by the presence of high plateau pressures, particularly those greater than 30 centimeters of water. This concludes the introductory material on ventilating patients with respiratory distress. The application of the physiologic concepts mentioned here to a patient ventilation strategy will be addressed in an upcoming video. Thanks for tuning in.